Well, good afternoon and welcome. I don't believe we have that many from the West Coast, but if so, good morning. This is Steve Conley. I'm the Executive Director of the American School Health Association, and this is another in a series of webinars. We're very happy to have you join. Today we're looking at the experience and impact of stigma among youth in psychiatric outpatient treatment, the role of the family, school, and peers partners. And during this webinar, Heather Gibbons is our communications manager. She'll be tweeting at the hashtag or # Psych Stigma, if you want to also play along there. That's PSYCH Stigma. Let me tell you just a little bit about the American School Health Association while we wait for others to wrap up and come in and join us. ASHA is a multidisciplinary professional membership of about 1,000 individuals. Our mission is to build the capacity of members to plan, develop, coordinate, implement, evaluate, and advocate for effective school health strategies that contribute to optimal health and academic outcomes for all children and youth. We are the publishers of the very highly regarded Journal of School Health, we affectionately call JOSH, and we're really pleased to have you consider becoming a member, and you can automatically start receiving. Many people have cut back on the journals. We still have a print copy that comes out monthly. If you prefer online, it's possible to go in online. You can get both the hard copy and the electronic. Today we have two presenters. I'm going to just very quickly introduce our section secretary for the American School Health Association, health chair. My apologies to you, Sylvia Huntley. Sylvia is at the University of Maryland School of Medicine, Department of Psychiatry, the Center for School Mental Health. And we're very pleased to have this as another in our series of dealing with issues related to mental health of adolescents and youth, and particularly focusing this month on parents and the importance of parental engagement. Once Sylvia has a chance to talk to you a little bit about the mental health section of ASHA, we'll go into and introduce Dr. Catherine Elkington, who is our primary lecturer today, and all that we present will be also available on our webpage. Give us about 5 or 6 days. For the ASHA mental health section, Sylvia, we'd like to hand you the microphone and let you begin by telling folks about this part of our organization.
Okay, great. And thank you, Steve. Good afternoon or good morning, depending on where you are at. To everyone on the conference line here, again, I do want to thank you as well as Steve and ASHA for joining this exciting webinar that we are hosting today. And as Steve mentioned earlier, this specific webinar began in a series of 2. The first one was presented in September, called It's Not Your Father's Shrink, looking at new developments in children's mental health service delivery. The video and PowerPoint slides that were presented then are posted on ASHA's website, which is easy to find. It is www.ashaweb.org. And I would just like to take a few minutes to share with you and give you a flavor of ASHA's mental health section. And if you are joining by way of your computer, there is a PowerPoint slide which shows the mission/vision, the benefits of joining the section, and some of the outreach and dissemination of work this section has been doing. The mission is to advocate for and promote mental health services and support in schools in order to improve the health and academic outcomes for youth. And we have been very active in trying to spread not only that mission with the mental health section, but some of the other sections that are under ASHA's website as well. We are working on various issues related to school health. We send out a monthly list served to section members regarding various topics such as training, grants, and research opportunities, as well as newly released documents and other helpful resources. We have developed and co-developed, along with other sections, several resolutions related to mental health and youth, such as suicide prevention and intervention, reducing bullying in schools. We are now in the process of looking for new section officers. I want to encourage you to become a member and to partner with us. And I believe that the next slide will tell you more on how to join ASHA's website. Thank you, Steve.
Thank you very much, Dr. Hunley. Some other benefits, if you look at the possibility of joining us in this community and family of professionals and parents who are very involved in all aspects of school health. I've mentioned the journal, and in addition to that, the listserv that Sylvia has just discussed. We also have access to our blog, the Pulse, that we recommend you check very frequently. Likewise, there is a Facebook page for ASHA. If you join that, you get information and breaking news on training, funding, other member questions and news immediately. And we highlight different issues each month. You can become a member in one section and two councils within the association, receive discounts on our publications as well as discounts on our conference and seminars. And you have free continuing education CE contact hours. And it's our hope that you'll also take a good look at the individual health insurance opportunities, which is a new member benefit that we have developed in the past year for our members. We want to thank partners for this webinar, sponsored in part by Communicare for health centers in Texas, and likewise the St. David's Foundation, which is based in Austin. They were very helpful with our previous conference in San Antonio, and we hope if you were not part of that conference that you'll consider holding your calendar for next October 9th through 12th in the beachside city of Myrtle Beach. Myrtle Beach is highly recognized for golfing, shopping, seafood, and shag dancing, and it's always a good meeting to go to in terms of the network and connections that you can pick up with other professionals, state-of-the-art, all across the spectrum of those professionals in school health. The continuing education offerings for this webinar, free for ASHA members. Non-members, we request a $30 donation for credits. After the webinar, you'll receive an email which leads you to a survey where you can submit for 1.5 chess credits or master chess credits if you have 70% or higher active participation in the webinar. Believe it or not, when you sign on, we have what we call a Santa Claus column. We can tell if you're being naughty and checking your email or if you're being nice and paying attention to the PowerPoint slides and the address. We really hope you will, and we hope you'll look for credit. Only email addresses from the webinar registration can be used for credits. It is now time to go to the meat of the program, and it's my pleasure to introduce someone that I've met by phone and email, and that's Kate Elkington. Dr. Elkington is a licensed clinical psychologist and an assistant professor of clinical psychology in the psychiatry department. She's an associate training director at the HIV Center for Clinical and Behavioral Studies at Columbia University and the New York State Psychiatric Institute. Her work examines the role of individuals, such as those with mental illness, substance abuse issues, familial and structural issues, and that correlates to HIV/STI risk behavior in vulnerable populations, including youth in psychiatric treatment, youth in the juvenile justice system, and youth perinatally infected with HIV. Dr. Elkington's work also focused on using the findings of her correlates work and to develop and evaluate an efficacy of HIV/STI prevention interventions for vulnerable youth populations. She's currently the principal investigator of developing a family-based HIV/STI prevention intervention for youth on probation. Dr. Elkington is working on a grant to develop a pilot test, family-based HIV/STI prevention interventions for youth and probation. Dr. Elkington also has clinical experience working with adolescents with a variety of psychiatric and substance abuse disorders and their families. We were very pleased that Sylvia and Dr. Dana Cunningham found Kate Elkington, and she was willing to work with the American School Health Association to present this program today. With that said, Kate, I turn to you.
Okay, thanks very much. So just wanted to make sure, can everyone see my slides?
You got it.
Yeah. Great. Okay, doke. Well, first of all, I just wanted to say thank you so much for asking me to come and speak with you today. It's really great to have an audience who's interested in learning about stigma as it relates to mental illness among youth. As I think, as we're going to talk about today, it's a really important area for us to think about. Okay. So I'm just going to ask a few questions of the audience so I know who it is that I'm speaking with. First of all, if you could select your profession from the choices that are provided. Okay. Do we have the poll results up?
Coming right up, Kate.
Okay.
Okay, those are the results.
All right. I don't see those. Okay, I can't see the results, but that's okay. Let's move. We can move on. So then the next question is if you can select where you choices that are provided.
Right.
And we'll give them to you, Kate, if you can't see them.
Okay.
Give folks about 20 seconds to hit the keyboard.
Poll results. We have 44% school or district, 13% mental health care, 0% in after-school programs, and 44% in community organizations.
Great. Thank you.
And Kate, if you didn't see the previous poll results, then I can share that also. We'll go back to that one. Current profession. We have our 60% are in our other category, 25% mental health workers, 5% for each teacher, guidance counselor, and nurse.
Okay, great. And then the third question, I have 4 questions in total. The third question is, so who works directly with youth who have mental illness?
I'll give folks about 15 seconds to respond.
So we have that moving along. So we have 56% said yes and 44% said no.
All right, great. And then finally, who works with the families of youth who have mental illness?
And again, we'll give you about 15 to 20 seconds to reply.
Okay, so we have 65% yes, they do work with families, and 35% no.
Okay, great. Thank you. So as we go through and talk a little bit about stigma today, and it's the experience of stigma in youth who have mental illness and the impact of stigma, some of this is definitely going to be pertinent to the work that you're doing. And as much as we can at the end, but also throughout, if you have questions, it'd be nice to try and open the forum up a little bit just so we can brainstorm a little bit together about what we can do as providers or people that work with or have contact with youth who have mental illness to try and offset some of the effects of stigma and to reduce their experiences of stigma. Okay, so the goals of this webinar are, the first is to understand the concept of stigmatization and how it occurs. The second is to understand how youth in psychiatric treatment experience stigma. The third is to understand the possible effects of these stigma experiences on youth. And then finally is to begin to think about ways in which providers, so teachers, mental health workers, guidance counselors, nurses, etc., who work directly with youth with mental illness, how we can think about ways of reducing stigma. Okay, so first of all, what is stigma? Well, Erving Goffman in 1963 wrote a pretty seminal book about stigma and the effects of stigma, and he described it as an attribute that is deeply discrediting, whereby it renders the individual from a whole and usual person to a tainted and discounted one. And so essentially, stigma, thinking about how it occurs, and probably one of the best ways to think about stigmatization is that it's a process, and that it involves both the individual who's been stigmatized as well as the stigmatizers, or the group that is doing the stigmatizing. And for the purposes of our presentation today, I want to talk about and use the framework that was developed by Lincoln Phelan, who developed a model of stigmatization specifically around dealing with mental illness. Now, stigma can be as a result of any kind of discredited, I suppose, or issue that somebody else deems is somehow renders the individual to be unusual or to be discounted or tainted. And so other things that can be stigmatized include having HIV, for example. And so stigmatization as a process can applies to pretty much anything really, not just mental illness, but that's what we're going to focus on today. And so Lincoln Phelan sort of hypothesized that the stigmatized individual is labeled undesirable by a larger, more powerful group, and they're set apart. And then as a result, the individual is seen as somehow not worthy compared to the larger group. The larger group discounts this individual, and they are subsequently discriminated against. And it is the discrimination is essentially the behavioral aspect of stigmatization. So that's how stigma basically occurs. And so this happens at both the individual level, so that involves overt or direct practices of discrimination against the individual. So that would include such things as being called names, being beaten up, or being rejected from peer groups. And then also stigmatization can occur, or discrimination can occur at the structural level. And that involves institutional practices that work to the disadvantage of the stigmatized person. And that includes things like being denied access to housing or employment, being denied access to organizations. There may even be legal sanctions or laws that are on the books that serve to discriminate a specific individual or group. And so as we're going through, I'm kind of building a model for you. I'm particularly visual, so this is for the folks out there that are similarly visual as well. And so if we're thinking about stigmatization as a process, we first talked about societal stigma, so that's basically being labeled as undesirable for whatever reason. And then how the the stigma is then played out via individual or structural level experiences. And then finally, and an important piece of the stigmatization process, is the effects of being stigmatized on the individual. And it's important to think, to also consider that. And so Lincoln Phelan referred to that these effects on the individual as social psychological processes. And basically, that's the stigmatized person's perception of what it means to belong to the stigmatized group. So, for example, that would be that others see me as less than, that I am not as good as. Their expectations of how others will treat me, in that they expect that they will be rejected and called names because they are now part of the stigmatized group and have been labeled accordingly. And also their methods of coping with these perceptions or expectations, or even their actual experiences of stigma. So, for example, an individual could choose to isolate themselves in order to avoid rejection. And it's important to think about these things. The expectation of being treated differently is oftentimes, it can be enough, particularly with people with mental illness, that the stigmatized person will alter their behavior in ways that can really limit their life possibilities. And this is where we start to think about what are the effects of stigma. And so this is the final part of the model. And so you can see that after the stigma, but either individual or structural level, these are then interpreted by the individual and captured through the social psychological processes. Okay, so I'm going to take a break here, and that was just a quick overview of stigma and how it works. Does anyone have any questions about that?
Questions can be typed into the screen, and we'll help you with that too, Dr. Elkington.
Okay. Okay, so I'll give everyone just a few more minutes. I don't want to rush through just in case there are any questions. But essentially, the process of stigmatization that I just described, it can really apply to any sort of stigmatized condition. And obviously today we're going to talk about mental illness. So it looks like we don't have any questions, so I'm going to move on. But feel free to ask questions as we go along and interrupt me. That's absolutely fine. So let's now then turn to stigma in youth. Ironically, to think about stigma in youth, we first need to turn to what we know about stigma in adults with mental illness. And this is because really the studies that are out there on stigma have primarily been conducted with adults who have mental illness. And these studies have found that the effects of stigma have been linked to having a devalued sense of self, so a low self-esteem, decreased mastery or agency, so basically kind of a belief that you're not able to sort of fill in the blank essentially, but don't have that general sense that you can accomplish and do things that are necessary in your life. A decreased quality of life, I mentioned that earlier, so just a general sense of their life not being as what it could. Non-adherence to psychiatric medication and treatment. So because of stigma, people are less likely to seek treatment, and once they do remain they're even less likely to remain in treatment because of stigma. It also been associated with impairment in social and leisure functioning, again, so sort of along the same line of decreased quality of life. Related to limited employment possibilities. If for whatever reason an individual with mental illness discloses to their employer that they have bipolar disorder or major depression, it's been shown that they're less likely to get hired. Also, people with mental illness are more likely to be living in poor neighborhoods, and in part as a result of stigma. They have poor access to adequate housing. With limited employment possibilities, they tend to be living in lower socioeconomic strata, and as a result living in poor neighborhoods. So thinking about youth now, most of what we do know about youth and stigma is whether or not youth without mental illness stigmatize against those youth who do have mental illness. And the various studies show that children as young as 5 have already developed stigmatizing views about those with mental illness. And that just goes to show you that within our society, the strength of the messages that are around about mental illness and what it means to have mental illness or to be mentally ill. And unfortunately, studies show that these attitudes in children, they become much stronger with age. Studies that have examined experiences of stigma or effects of stigma in adolescents, they've been few and far between. And those that have examined their experiences have shown that stigma in youth with mental illness is associated with, as with adults, less likelihood in wanting to seek treatment and get help, and then also to in treatment. So why should we care about stigma in youth? Well, one of the key goals of adolescence, or developmental goal of adolescence, is to develop a sense of who you are and a solid sense of who you are. And this developmental task occurs against a rapid sort of backdrop, if you will, of physical, cognitive, and social change during adolescence. And it's also during this time that peers and partners become much more important, and their opinions of an individual becomes much more important. So if you're thinking about an adolescent who's been diagnosed or struggling with mental illness, you can see that the difficulty of developing an identity may be even more difficult for a youth who has mental illness, who they've been labeled with a diagnosis, or someone who's having mental health problems, and they now have to incorporate this into part of their identity. And as you, if you think about what I just said about the fact that children as young as 5 are aware that having a mental illness is not seen as a good thing, so for an adolescent to all of a sudden be diagnosed with mental illness, they're going to recognize that in our society, they now are part of a lower valued group or a lower status group. And then persistent experiences of stigmatization during adolescence may result in internalizing those experiences and sort of really strengthening an identity of oneself that incorporates the idea that I am less than, I am not as good. And the effects of stigma, as we've seen in adults, they're long-lasting. It has influence across the lifespan, and has considerable ramifications for the individual's well-being and adjustment as an adult, not only as an adolescent. And so therefore, if we're thinking about stigma in adolescence, the period of adolescence is really a critical time to intervene. And so thinking about stigma in youth now, I think, is a really important period for us to consider. So in the absence of really a lot of in the absence of really any information about youth and with mental illness and their experiences of stigma, I, with some colleagues, set out to conduct a series of interviews with 24 youth who are in treatment. So these are youth who have already been diagnosed and are currently receiving care. So it's important to think about that. Their experiences may be a little different from youth who are struggling with mental illness and have not yet gone or sought services, or even those youth who have sought services and since left. Okay. The youth were aged 13 to 24. And we wanted to know we wanted answers to the following questions. The first was, do these youth recognize the stigma attached to having a mental illness? We think that yes, they do, but we really wanted to know that. So if you think about the figure that I showed you before, that's a societal stigma. Do they recognize that? Second, do they experience stigma, and how are they stigmatized? And so that's sort of looking at the individual and structural experiences of stigma. And then finally, we wanted to know what were the potential consequences of stigma in youth. So we know a lot about what the effects of stigma are in adults, but we really have very little idea about the effects in youth, aside from, as I mentioned before, they're less likely to seek or remain in treatment as a result. And so think about the model. First is, do they recognize stigma? How are they stigmatized? And then what happens as a result? Okay, so who did we interview? We interviewed 24 youth who were in psychiatric outpatient treatment. Just over half were male, 75% were Hispanic. There were 11 youth who were aged 13 to 17 and 13 youth who were aged 18 to 24. The mean age of the group was 16 and a half, sorry. Just under 30% had a psychotic disorder, and so that's schizophrenia, bipolar disorder, schizoaffective disorder, or psychosis, NOS. Half of them had major depressive disorder or dysthymia, and then the remainder had generalized anxiety disorder, ADHD, panic disorder, or adjustment. So the first question, do youth with mental illness recognize the stigma attached to having mental illness? Well, unfortunately, yes, they did. So of the 24 youth that we interviewed, 23 stated that they believe society as a whole saw that those with mental illness were different. And different was not in a good way. Different was seen as something that was bad. And these are some of the quotes from the interviews. So one male, age 20, said, they see you as not necessarily a mental case, but they see you different. So you're different. You're like outcasted. Another girl, female, age 16, mentioned, some people might say, I don't want to be by you because you might just wild out on me for no reason. Youth also talked about how people with mental illness were typically seen as violent or dangerous, and this was often blamed on the media. One youth mentioned, I think it's because usually when you see images of a mental institution on TV, it's perceived as a place where dangerous and violent people are kept. So they'd see me as some violent person who's going to therapy for some random violent reason. And if you think about it, so this is a 16-year-old boy who is going through adolescence, going through the turmoil of that developmental time period that we've all been through and know well, and he's also managing this sort of secondary identity as walking around with a mental illness and knowing that if people knew he had a mental illness, he perceives that people are going to think he's dangerous and violent. So you can start to think about the burden that stigma is going to have on an adolescent, and particularly as they age. Several youth also stated that people who didn't have a mental illness would not want to date them or be friends with them. And they thought that they would not make good romantic or sexual partners. In particular, some youth expressed beliefs that partners who didn't have mental illness wouldn't consider them as dependable and wouldn't want to date them. They felt that mental illness was something that most people don't want to deal with or manage, and that the partner would consider the mentally ill person to be a burden in the relationship. One male reported, it might scare them too. It's like, oh crap, now I have to be going with this person that has mood swings, and the mood swings might scare them, or knowing that they're suicidal all the time. It drags you, because you could be strong in a relationship for a long time, but then it's just that mentally ill person becomes dead weight. And so this is how they are seeing, they perceive other people without mental illness see them. And so the next question was, do youth with mental illness experience stigma, and if so, how? Well, unfortunately, almost all youth reported experiences of stigmatization. 17 out of the 24 reported specific experiences. So let's talk about how this occurred. So remember about the model. We have the individual on the structural levels of stigma. So how are they stigmatized? So this is what we're looking at right now. So primarily they were rejected by others. They talked about experiencing changes in their relationship with other people. So if they weren't outright rejected by people, then they noted that their relationship somehow changed. And these things typically occurred following the youth's disclosure of their diagnosis or the fact that they were currently in therapy. So who rejected these youth? Well, they talked about peers, their friends, and this happened, these were the friends that were both in their neighborhoods and also at school. Youth talked about the fact that their friends had rejected them and that they lost friendship. A lot of people got scared away. People were just afraid of my mental illness. Another youth describes, I have days when I'm just real serious and depressed. And when she sees that, she stays away from me. And then at school, some youth also talked about experiencing stigma and discrimination at school, and it was subtle, particularly by teachers. One boy notes, he just raised his eyebrows as a teacher, but he didn't say anything. It was like a quick, sudden thing, and then we just moved on with the conversation. It was like he was surprised, like I seemed so normal or something. And so this was a boy describing when he told his teacher that he was receiving treatment for mental illness. And then finally, youth described stigma, a lot actually, of stigma occurring within the realm of the family. And this occurred by family members either rejecting or denying illness. One youth with bipolar disorder described a visit from her grandmother following her return from the hospitalization. And the grandmother said, she's like, you don't need to be taking no pills because you're not sick. And the grandmother, when she was saying this, was really very angry. Then there also the youth talked about experiencing stigma, subtle messages of stigma based around concerns about the shame that it would bring to the family. People described the parents or family members questioning why they had to talk to a stranger about their problems, and that this was something that they should handle within the family themselves. And then also the issues of stigma came in subtle messages about what it meant, what the youth's illness meant about the parents. For some family members, there was a shame about how the diagnosis reflected on them. As one youth with bipolar disorder described his mother. But his mother, she still has problems accepting that I have bipolar disorder. I think she thinks it reflects on her. When people say, oh, your son's bipolar, and then they start thinking, well, you're kind of crazy yourself. Youth also talked about how there were changes in their relationships with family members and also friends, about how they treated them following either their diagnosis or disclosure that they were in treatment. Some youth described the fact that they were no longer trusted, particularly by their parents. For example, they weren't allowed to use a stove, or they weren't able to go out in the same way that they were before. And I think that this is summed up amazingly by a 13-year-old who I asked the question, how people or whether people treated him differently. And he responded, it was either people tried to treat me better, like I have some disability, and I had some people treat me worse, like I had some disability. And so then I asked, and why do you think people treated you better? Because they thought something was wrong with me. Oh, well, and why do you think people treated you worse? Because they don't like people that have something wrong with them. And so for this 13-year-old boy, he was well aware of the fact that he had a diagnosis of bipolar disorder and what that meant to people around him. So then we also asked about stigma at the structural level, and we didn't find any. And this could be because the youth, because of their age, they're protected. Given that within the family, they may be protected within the realm of the family. There are also medical privacy laws. And so that, for example, when youth had doctor's appointments, which would require that they have to miss class, they don't have to say why they're going or what doctor they're going to see. They just have to say they're going to a doctor's appointment, and so nobody knew. Also, psychotherapy appointments were available before or after school hours, and so the youth were really able to kind of keep their therapy appointments and the fact that they were in therapy. If they wanted to, they could really keep it to themselves. So then we asked, what happens? What are the psychological processes or the consequences of these experiences of stigma within the family, with their friends, both at school and in the community? Well, shame. There was a message or a theme that was common in a lot of the narratives and stories of the youth that we interviewed. They had internalized the messages from the larger society and their own individual experiences. And they articulated beliefs that having a mental illness did make them different to everybody else. They considered it that they were less than others, and they considered it that having a mental illness was a vulnerability or a flaw in who they were. They also saw themselves as undesirable as friends or partners. And some even describe being undeserving of romantic or sexual relationships. They believed that they had limited ability to choose either those who would be friends with them or that choose their own romantic or sexual partners. And as one youth noted, do you feel like you can choose who you can go out with or who you want to be intimate with? I don't think so. They choose you, you know. Why is that? I don't know, because they seem to not understand a mentally ill person. So this individual, and we'll come back to him in later on, but he really believed that he didn't think that he could choose who his partners were, in fact, that he had to be chosen. And another female noted, most of the time I'm depressed and boring. I don't deserve to be with that person. That person is too good for me. And that's how she kind of felt about herself. And when she talked about her boyfriends or people that she wanted to date, this is kind of the theme that kept coming back for her, was that she really wasn't good enough to be with these people, and why would they want to be with her? So then we started asking questions about, well, how is it that the youth then manage the shame, the fact that they've internalized messages from their environment that they are indeed less than, and that they're not as good as everybody else or those without the mental illness. And they described these coping mechanisms that they attempted to manage and minimize possible stigmatization and rejection from others. So first of all, they distanced themselves from the label of being mentally ill. And some of the youth responses indicated a subtle hierarchy, if you will, of stigmatization, as youth use language that distance themselves from those who consider themselves crazier than them. So, for example, one youth commented that other patients she'd seen in the clinic were crazier than her. She says, I've seen crazy people here. They talk to themselves and stuff, and it makes me feel a little better because I'm not that crazy. I'm not crazy like that. And so by being able to agree with the idea that people with mental illness are less than, but that it didn't apply to them because they weren't part of that label. So they could still agree with the general message that society was telling them, that people with mental illness aren't as good. So they didn't have to kind of readjust how they saw things or understood the world with respect to that, but that they just simply said, well, that just doesn't apply to me because I'm not crazy. And one girl, I think, kind of illustrates this point. So, do you remember that guy from the Virginia Tech thingy? Yeah, that's a crazy guy. That's a crazy person. I'm not that. And so for this young girl, she's articulating the whole someone with mental illness, they're violent, they're crazy, and that's the definition of mental illness, and that's not who she is, and so she doesn't identify herself with that.
Okay, can I interrupt you here with a question?
Sure.
Beverly has asked, actually it's two parts, if you found any of the study subjects could remember stigmatizing others before they had in effect their own issues, if before their case they had that experience. And then the second part of that is if you've seen cultural differences in this issue.
Right. So the first question is an absolutely excellent question, and we did not ask that, unfortunately, and I wish we had have done. The majority of youth had been in treatment of some form or another for about 5 or 6 years. So if you think about the mean age of the group was 16, and most had been in treatment for about 5 years or so, 5 or 6 years, they were probably 10 or 11 when they first started. And, they may have been sort of too young to, I don't know, the answer to that question. They may have not been engaged in sort of stigmatization of others at that age, but it's a good question, and I really don't know. Then the question about culture is really, really important. The majority of the sample were Hispanic, and mental illness is considered different in different cultures, absolutely. And I think that the piece that's really important to think about, particularly with youth, minority youth, so not only are they developing their identity during adolescence, they're also developing their identity as a youth of a specific race or ethnicity, which is, of a minority, so it's different from the majority. And then also, on top of that, if they have a mental illness, then this is a sort of an addition or added layer of sort of identity development that they're wrestling with. The context of mental illness in culture, a lot of it has to do with the relationship of a specific culture to the treatment system, and particularly for Hispanic, African American cultures, there tends to be historically, and for good reason, a large distrust of the healthcare system and of the psychiatric system. And so there tends to be a reluctance and a resistance to acknowledge or identify with labels and treatment when it pertains to mental illness because of that reason. And so that's certainly something to think about when we're thinking about experiences of mental illness and stigma in youth. Okay, I hope that answers your question. All right. So in addition to sort of moving themselves away from the label of what it means to be mentally ill, or the definition of mental illness, so that it didn't necessarily include them, some youth use silence and withdrawal. And so basically they kept quiet about their mental illness, and they withdrew from those who they thought might reject them. And they noted that they struggled to really tell people that they were either diagnosed or currently receiving treatment for a mental illness. They thought it would scare people away or it would create a barrier. And we asked them the question about sort of like when would be the right time or when would be a good time to tell somebody that you were in therapy. And a lot of the youth really didn't know, and they said that there probably wouldn't be a good time to do that. In general, the youth just chose silence and secrecy and just preferred not to tell anybody about the fact that they had a mental illness or that they were in therapy. And in some instances, the youth would lie about, for example, why they had been to hospital, if they had been to hospital for psychiatric reasons. One boy described that he told his friends that he had had pneumonia rather than tell them that he had been hospitalized for psychiatric reasons. In addition, in some instances, youth use relationships, and here, but I'm going to focus specifically more on romantic and sexual, but they use these relationships as a way of avoiding feelings of rejection or to sort of distance themselves from the idea that someone with mental illness is less than and is not a good partner. And they talked about maintaining unwanted relationships as a way of avoiding rejection and feelings of being unwanted. And so one youth noted, we were talking in general about, a youth was talking about a friend of his, and actually some of the youth did that. They talked about friends versus talking about themselves, and that may have been because the subject matter that we were talking about was really quite difficult for some of them to admit to, and so they were more comfortable talking about the experiences of a quote-unquote friend. And so I asked the question of this friend, why do you think she goes out with someone that she doesn't really like? And they responded and said, so she won't be alone, so she won't feel bad about herself, so she won't think that nobody wants her because of any of the issues that she has. And so if you think about sort of maintaining a relationship that's not really wanted, in concert with that, some youth described that they would become then less assertive in a relationship just as a way to maintain it and to avoid being rejected or left by the partner. And so that they would be described being more accommodating and not sort of putting themselves forward in a relationship and getting their own needs met. For some, that look took on the form of being sexually passive. Some of them described struggling to request condoms. One female described that she didn't want to ask for condoms. She had bipolar disorder, and she said that if she asked her partner to use condoms, well, then that just fulfilled every stereotype of a promiscuous person with bipolar disorder. And so she really didn't want to do that because she felt like if she asked for condoms, then it meant that she was having a lot of sex. And then another male, this was the boy that the man that we talked about earlier, who said that he didn't think he could choose his partner. And here he described trying to get his girlfriend pregnant. And I asked, does she want another baby? Yeah. Do you think it's a good idea? No, she's not ready. She's not ready for that. Are you ready? No, I'm not ready. Not ready, so then why are you trying to do it then? Just to keep her. So despite the fact that he wasn't ready to become a father, which is a pretty significant role to take on, he was trying to get his girlfriend pregnant because it was what she wanted, and if he didn't do it, he was afraid that she would leave him. So that idea of sort of being abandoned and the need to keep a partner is really powerful, particularly for the older youth. Now, it's important to also think about the youth. So I said that the majority of youth described experiences of stigma, but not all. And there were 7 youth who, when we asked them about it, they really could not come up with or describe or didn't talk about any direct experiences of stigma. Their friends didn't stigmatize against them. Their family were very supportive. This is as they described it. Yet, interestingly, all 7 described internalized stigma. They still believed that they were somehow less than because of having a mental illness, or that they engaged in behaviors to manage their, quote-unquote, their stigmatized identity. So they didn't tell people that they had a mental illness, despite the fact that they'd never experienced any rejection or name-calling or anything like that by anybody else. And so they were still engaging in those behaviors. And I think that the point here is to really remember that messages from the larger society or the community are so powerful for these youth. And so just to kind of summarize the points that we've gone through. So the first question was, do they recognize stigma? Yes, they do. How are they stigmatized? They're stigmatized by their friends, their experiences within their family, and at school and within their communities. And then what happens as a result? Well, they internalize these negative messages, either the messages from their friends and family or from the larger society. Some remain silent or withdraw from others. They distance themselves from the label of being mentally ill as a way to manage. And then for some, they maintain unwanted behaviors. And the link there, obviously, the link there to risk behaviors, to engaging in unprotected sex, or possibly other behaviors, being more open to peer pressure as a way of maintaining relationships and not being rejected by peer group, the risk there is quite high. So does anybody have any questions about what I've just mentioned, the experiences of stigma and its potential consequences?
And again, this is Dr. Conley. You can type in questions for Dr. Elkington, and we welcome them. You're doing well, Kate. Thank you.
Maybe I have a question for any of you. Was any of this surprising, or is this something that, particularly those of you who work directly with youth with mental illness, is this something that you see and that you know?
Kate, I myself am rather curious about whether the response from the grandmother that you don't need to take those pills, did you see a lot of denial coming in from the families?
Yeah, a lot of denial, that you're not really ill, the medications aren't necessary, you don't need to be in treatment. You can just talk about it with us, you don't need to talk about it with a stranger, it's not necessary. And the quote that I used was from a grandmother, but actually typically that denial came from fathers. The youth described that it was their fathers who tended to reject the label or reject the fact that they needed treatment.
surprised me much. We do have another question that came through, specifically related to schools. Now that the professional has the awareness of the impact that stigma can have on youth in schools, how can they act to best serve those students?
Okay, so that is a great question, and that's the final part of the presentation. So why don't we go through that, and then if I don't directly answer your question, I will try to. And definitely here I see after-school support groups help, definitely. Let's go through, and as much as we can, if people want to just type in or chime in with their thoughts and suggestions about what providers in different settings, whether it's school or in mental health treatment settings, what they can do. I think it would be, it's great for a discussion, and I'll try and bring it alive. So, and then I have another question just before I go on. Linda asked, how is stigmatization of mentally ill patients differ from stigmatization related to physical problems? It's really not. And the process that I'm describing here is likely that people who have physical problems, I'm assuming that you mean maybe physical disabilities, maybe it's likely to be very similar in the sense of maybe feeling less than, feeling shame for whatever reason. But I don't know, and I'm not aware of work that's been done, particularly with youth who have physical disabilities or limitations. But the process that we're describing here can probably apply specifically to a lot of different stigmatized conditions. But we need to kind of ask the youth and ask the questions in order to figure out what are the specifics, what's unique about specific conditions. Okay, and so then I have another question from Colleen who said, to piggyback, as a school psychologist in an inner-city school, we are often frontline for mental illness, and it's often very difficult to communicate the knowledge associated with that illness and to encourage follow-through for treatment. Yes, I agree. It can be very difficult. I think there's a sort of a two-phase step to getting somebody into treatment. The first is the acknowledgement that the individual needs treatment, right? They have to recognize, in fact, a problem, and then that they need help and treatment. And that the stigma associated with having a mental illness can really get in the way of coming to terms or sort of, saying, yes, I do, in fact, suffer X, Y, and Z problems, or I struggle with this, or struggle with depression, and I need to get treatment for it because of what that means about them as a person. Okay, so let's go through. So what can we do? So just sort of preamble. Over 10 years ago, the Surgeon General identified stigma as the most formidable obstacle to the future progress in the arena of mental illness and health. And he listed the reduction of stigma as an important public health goal. And we're still, sort of 10 years later, it's still a key issue and a key concern. Research and clinical anecdotes tell us that teens will avoid seeking help and will not remain in treatment due to stigma, and I think basically Colleen's comment just speaks to that. And what we also know is that interventions or anti-stigma campaigns that are just targeted towards the larger community are not always successful. We know this from other stigmatized identities such as HIV. Having a community kind of prevention program for HIV, to reduce HIV stigma, does not always translate to improved outcomes for the individual. So I think that the results from the interviews shows us that we also have to address stigma at individual and family levels as well, in addition to school. So what can we do? So thinking of those who are working directly with youth with mental illness. First of all, I think of beginning a discussion about an open discussion about the effects of stigma. For about 90% of the youth who we interviewed, this was the first time that anybody had asked them about stigma. No one had talked to them about it, or their experience with it, or what it may do. And so I think that first of all is really important to get it on the table, and so that we recognize that this is something that they deal with. We also need to talk about and explore coping behaviors. What are these youth doing? That for some people, they're choosing to remain silent, they're withdrawing, they may be maintaining relationships that they don't really want, whether that be sexual, romantic, or peer groups. And so it's really important to figure out how are they coping with stigma. Is it in a healthy way or not? Then, importantly, we need to, so that's the first thing, is to let's just have a conversation about it. The second is to then address some of the internalized stigma, the idea of self as being less than. And we can work with the teen to help them build mastery and self-esteem, to really, once you've sort of like laid it out on the table that this is indeed an issue and an experience that they have, and to get them to the youth, to get a teen to really openly talk about the fact that they have a mental illness and that they have internalized that this then means that they are not as good as the next person, it's no small feat. I mean, it's really difficult to do. A lot of the youth that we interviewed, first of all, rejected that was even a possibility for them, that, yeah, they knew people stigmatized about people with mental illness, but that didn't apply to them, and that they didn't have any problems with it. It wasn't until we asked questions in various different ways about their experiences with their friends or family members, asking specifically about who have you told about your mental illness? No one. Well, why not? When you came home and told your mom that you felt like you should seek treatment, or that someone at school had recommended that you do that. There's experiences in the family. You then begin to sort of hear that they had in fact been stigmatized, and so it's really important to kind of get the youth to be comfortable in talking about it and identifying that these are their experiences and that this is in fact the influence and the impact on them. Group-based interventions can really help. They can provide support where teens can share experiences. They can learn to develop healthy coping responses and support from other teens who have mental illness and are going through the same thing. In one of the mental health clinics that where we interviewed some of the youth, there was a group that was ongoing that a couple of the youth talked about belonging to, and that was a place for them where they really felt like they got support and this sort of social support just from being with other teens who had similar problems and how they were managing it. And then it's also important to address the risk behaviors that may stem from attempts to manage a stigmatized identity. Working with the family. It's also then, so there's a lot of stigma that may exist within a family. I think in the data that we were just looking at, the families they tended to be primarily Hispanic, and so that these experiences may be specific to Hispanic culture, except that in some other work that's just started to be done with adolescents and stigma, that have looked at among white and also African American youth, they seem to have similar experiences within the family. So I don't think that these family findings are unique to the Hispanic, but it's something to keep in mind. But the idea of the family-based anti-stigma prevention program, so that not only are we just dealing with the youth and helping them manage having a stigmatized identity and sort of building a self-esteem and mastery, but also getting the family on board. And have them talk about the messages that they may be communicating to their teen without even knowing it, the things that they can be saying. But also to promote frank and active discussion about what it means to have a teen with mental illness, and depending on the disorder and how severe it is, just how difficult it can be to help the teen manage their disorder, take their medications, and the possible disruption that that may occur within the family unit, but have discussions about that and ways to manage it versus a lot of the sort of the denial and silence that we saw, because that's probably not going to do anything to help the youth develop a positive self-concept or sense of who they are. And then it's important to leverage the family as support for youth. There were definitely some youth who described that their family as being very supportive, that it wasn't a negative experience for them. And for these youth, it was very important that they had at least, a couple of individuals who they could be completely open with, who knew all about them. It felt like a relief for these youth that it was someone that they could be very open and honest with, and that they weren't continually hiding or worried about somebody finding out with folks with their family, because they knew and they could be who they were. And then working with the community. So local CBOs can definitely educate and increase awareness of stigma. This is targeting people that don't have a mental illness, right? So that there are programs or sort of like PR campaigns that can be run. Also, school-based anti-stigma programs. So not just working with the youth who has mental illness to help them manage it, and that could be after-school programs, groups, one-on-one working, sort of if you have that time. But then thinking about the larger school and taking an anti-stigma campaign initiative and developing that and making it school-wide. And these state programs should dispel myths associated with mental illness. It's not contagious. That was something that a couple of the youth said, that people thought because they had mental illness that they could catch it from them, that they're not necessarily violent, that, sort of in the media messages as well, that's not true. And also to de-exceptionalize mental illness. So, and this is both positive and negative, and so that the idea that it's not anything special to have a mental illness, but that is also the one that I wanted to bring up is that people also, they exceptionalize mental illness, and this is done in the service of trying to decrease stigma. But I have a list here. It says famous people and mental illness, and it lists Isaac Newton, Beethoven, Abraham Lincoln, Vincent van Gogh, Winston Churchill, Virginia Woolf, Linda Hamilton, Jane Pauley, K. Redfield Jameson, John Nash, Carrie Fisher, Vivian Lee, Eugene O'Neill, Brooke Shields. These are all Leo Tolstoy. These are all famous people with mental illness, and the idea being that, just because you have mental illness, you certainly aren't less than. And I think it's sort of a great way of increasing awareness, but at the same time, it can also do us disservice, because what happens to the mom of two who lives next door, who isn't exceptional in any way? She's just like you or I, and she has bipolar disorder, and she's not a world-renowned novelist or a famous composer, but that she's just a mom, and maybe she's working, maybe she's not, and she has bipolar disorder and she's managing it. And I think that face of mental illness in a lot of stigma campaigns is missing. And so I think it's really important to de-exceptionalize mental illness, not only to say it's not unusual, but then also to say, but just because having mental illness also doesn't make you extremely talented in any other way as well. And just finally, I want to end the fact that it really isn't unusual. A large national U.S. study a few years ago found that 1 out of 2 people will experience a mental disorder, so not necessarily just having problems with mental health, but an actual clinical disorder in their lifetime. So 1 out of 2. So mental illness really is not exceptional. So psychiatric illness is neither unusual nor restricted to a troubled few, and I think that from a sort of societal perspective, if we can get this message out, I think that would go a long way to reducing some of the stigma that these youth are experiencing. And that is the end of my presentation. I just want to acknowledge the funders that were contributed to some of the work that I did. And then I wanted to open it up to any questions that anybody has, or any thoughts about other things that can be done as far as addressing and targeting stigma.
Kate, do you see the question related to where the teen support group is located in relation to the clinic? Where is it located?
Oh, so within, where is the clinic that the teen support? Yeah, it's in the New York Presbyterian Hospital, which is the hospital that's associated with Columbia University Medical Center, where I am right now. So it was an adolescent clinic within Presbyterian, and it was a group that was being held there.
And do you think there's any additional resource information that that group might share with our attendees?
I can certainly ask them. I think it was a pretty informal thing. It was sort of a weekly thing that a weekly group that some of the youth just went to, and I don't know that if it was specifically about stigma per se, but they definitely touched on just what it was to be, managing, dealing with having a mental illness, and I think that some of these issues were talked about.
Well, Kate, I want to thank you. I thought that was a very interesting report, and you were very succinct and it was very great for me to hear and to look in terms of as we serve adolescents with a variety of mental illnesses about the stigma they face. Quite often I've seen it with physical disabilities, which are much more prevalent in the sense of visible, but here we have a mental illness which perhaps is not that visible. As you said, in that one example, or one of the young men said his teacher didn't see any kind of reason that he would be identified that way.
Right.
Okay. We will be posting your slide presentations as well as a tape recording of the entire event on the ASHAweb.org webpage for folks who perhaps didn't make it today, or if you want to review again. And Kate, American School Health Association, the Board of Directors, and our members and volunteers, I want to thank you very much. I'm very delighted that Sylvia and Dana tracked you down and we were able to get you to present this today. And I hope you work with us again.
Yes, thank you. Thank you again, Kate, and thank you, Steve.
No, thank you. You're welcome. This was great.
I'm really pleased. I should say we have another next week, the last this year, that we are hosting, using Dr. Shannon Michael and Dr. Joyce Epstein, and they're going to be looking at engaging parents to foster healthier, more successful students. There's a number of specific materials that are soon to be released from the Center for Disease Control, specifically the Division of Adolescent and School Health, and we work very closely with them. We had to move that date up because CDC has really expanded their impact on this work, so that our original date of the 15th is a lot of presentations and a Twitter event and a host of other activities, so that if you did register for the 15th, we need to back that up. It is 2 o'clock, same time Eastern that we started today, and that is on Wednesday, November the 14th. And let's back up and give you one more question, Kate, if that's okay. Are you aware of any differences related to stigma from the school-based setting compared to outpatient or community-based?
Unfortunately, the answer to the question is I don't know. The youth that we interviewed, they were all receiving outpatient treatment in a clinical setting, so we didn't really have we weren't able to ask that question. We didn't have any youth who were experiencing treatment in the school-based setting. That's a really interesting question. I would say differences may be the degree to which the youth felt like it could be the receipt of mental health services in school would be confidential. A lot of the youth, as I mentioned, sort of chose silence around their mental illness and really didn't tell anybody that they were in treatment. And given the laws and that are in place, the medical privacy laws, they didn't have to. And because their treatment setting was sort of entirely independent from their school setting, people really didn't have to know about it. And so they may have been able to manage experiences of stigma a little bit that way. So with a school setting, I think it would largely depend on how confidential the services were, and if people, if for example someone was called up in the middle of class to go and see, Mr. So-and-so, and everybody knew that was a mental health counselor, you may see a different impact of stigma there. It would just depend on how it was handled.
Very well put. Nice answer. I want to thank those of you that joined us for today and had a chance to listen and meet Dr. Elkington. And again, Kate, I want to thank you, and we need to thank our sponsors for this webinar, which again is Communicare and the St. David's Foundation, who were extremely supportive of our conference held in San Antonio in October. And once again, the annual American School Health Association Conference will be in Myrtle Beach next October, and that is the place to be to find state-of-the-art discussions. I'm hoping we have an even greater number of presentations related to the mental health area. And Sylvia, help me get that word out. I know we're recommending credits for psychologists. We had counselor credits in Texas, but we're hoping to really increase the and sharing of information related to mental health issues in children in schools. And again, Kate, Sylvia,